Coming up.
The aftercare can be stressful, but reflux for 18 months walking around the house is a lot more stressful than maybe 2 weeks of a baby giving you a hard time.
Yeah.
So true.
And having a kid who can nurse for 2.5 years, if that's what you want. So
as well as the stress of the stretching is hard, but I always tell parents, like, it's a lot easier when they're babies versus when they have teeth because of the biting thing.
Yeah.
We have a special offer for our Munch Bunch listeners. To book a virtual consult with Megan, she's offering a discount of $25 off. Just email her, Megan, at nwmyofunctionaltherapy.com or through her website, www.orofacial-myology.com. To book a virtual consult with Kimmy for the $25 off, email her mouthmusclememory@outlook.com or through the website, www.mouthmusclememory.com. Now on to the episode.
Hey everyone, welcome to the Munch Bunch Myo podcast. I'm with Megan Vanoy, my bestie, co-host, Myo gal, and we have Dr. Larry Kotlow on for part two.
Part two. We suckered into coming back again.
And we're going to be talking to him today about his protocols on wound management and all things after the frenectomy, which is oftentimes a hairy part of the process. So Dr. Kotlow was with us last time. If you haven't watched that episode, go back and watch it. It's very, very good. So we'll be talking to him now about what is wound management? What does that even mean?
Dr. Kotlow, talk to us. So, first episode, and please, yes, everybody go listen to that because Kimmy and I were having all the feels after that episode. What is, we have this wound management, aftercare, all these things get thrown out there. And we also see a lot of clashing information about what people should actually do versus what they shouldn't do. And so will you just give us a little bit of background about what aftercare even means and what that means to you for your procedures?
Okay. So you got a lot of experts who think they're experts out there, and they have their own techniques, and they some of it's overkill, and it does create oral aversion. And some of it is the other direction. They don't do any aftercare. So as I mentioned earlier when we started talking, I think aftercare begins really before care. So if we talk about an ideal situation, when we get children, let's say 5 years old and above to start, this is where I'd like, if we're going to do it, myofunctional therapists to come in, some body workers. And we start to talk about the infants. It's the problem is we have to look at what kind of a restrictive tie do we have. And if you go to my classifications 1 through 4, where 1 is at the base of the tongue and 4 is at the tip of the tongue, I don't like to use the word posterior tie. I use the word distal, or I class 1 or 2. And when you're to the tip, I class 3 or 4. So when you have those real tight ties, it doesn't matter what the pre-care is, because you can't, if I put a rubber band on your waist and one on your arm and connect them and give you a 10-pound weight, you can't do it. But if I cut the attachment, it's easier to do. So sometimes pre-care means just getting your fingers in the baby's mouth, putting your fingers in, moving it around, because we don't want to get oral aversion. Now, I've done probably 40,000 laser surgeries, and I don't know really, my patients, to my knowledge, have had any problems with oral aversion. Excuse me. So let's talk about the reality is some patients can't afford things which are outside their insurance company, and they can't afford to go out. But I'm not going to turn them away from my practice, because even if they don't get this kind of care, it's more beneficial to release these restrictive ties. So after whatever pre-care is necessary, and we evaluate it and we do the surgery, I tell the parents, the surgery for me is relatively straightforward and easy, but You need to be able to make sure that what I do succeeds. So if you're a tongue or a lip, and let's just say it's here, and I separate them, you have raw skin here and raw skin here. Now, when an ENT takes a pair of scissors and only cuts that much, they don't do any stretching. Okay, because scissors don't do the job in my mind. And then you'll get people say, well, what studies prove that? Well, I think it's unethical at this point, but we know lasers in my hands. I've been doing I use the electrosurge, I use scalpels, I use scissors. And to me, the laser is less invasive, less collateral damage. It's not a true cut. It's not a burn, and it seals the vessels. So you really get bleeding. There's very little swelling. Lasers come in different types. So you have hot lasers, which cut, and cold lasers, which call photobiomodulation, which reduce the inflammatory process. So before we do any surgery on the older kids, especially, we use a low-level laser and topical anesthetics. So after the cut, we can laser also, because that's going to stop the inflammatory process. So my patients don't get swollen faces. The amount of discomfort is minimal afterwards. You can use some of the homeopathic medications, Aftercare, arnica, and things like that, but that's between you and your lactation consultant, because some believe in that stuff. I don't care one way or the other. I do give my patients a combination of 1 drop of clove oil mixed in 10 cc's of coconut oil. Use it if you think the baby is uncomfortable. I'm not going to sit here and say I'm a homeopathic dentist. We do use lasers with very little drugs. We don't pre-medicate most of these kids. We keep them out of the operating room. We keep them out of general anesthesia. And that's also a concern to me, because if you've got to put a baby in the OR to do the surgery, that means the aftercare is going to be more difficult. So let's talk about, what are we doing? We're doing the cheeks sometimes. We're doing the upper lip sometimes. We're doing the tongue. And the aftercare is going to be different for all three. So the cheeks are relatively simple. It's a small little incision, and you're just going to pull the cheek up towards the eye. When I go 1, 2, 3, 1, 2, 3, 1, 2, 3. With the upper lip, again, we're going to take it and we're going to pull it all the way to the nose. Right. 1, 2, 3, 1, 2, 3, 1, 2, 3. So when we do your frenectomy, you'll know what to do. Okay. And that's good visualization. You can see it. I don't think we have to get into the conversation of whether you should do buccal ties or lingual ties or tongue ties and labial ties, because it's a moot question as far as I'm concerned. You know, people will say, well, what did they do 200 years ago? Well, remember, life expectancy wasn't very long. Babies died. You didn't have formula. You had midwives who used their fingernails. So you can't equate the question, why? Also, breastfeeding alone, you know, back in those days, every poor person would do it because you had wet nurses and mothers who didn't nurse. Today, it crosses all socioeconomic boundaries. Everybody wants to nurse because we know it's what's best. That doesn't mean if you don't breastfeed, you're a bad mother, because some parents are drugs, they can't do it, they've had surgery. Okay, but proper diagnosis beforehand solves a lot of problems. But if you don't do the aftercare, so what's my protocol for aftercare? Well, number one, like I said, I give parents a little bottle with 1 drop of clove oil dissolved in coconut oil. And they don't have to use it, but it's a little bit of an analgesic. We know that clove oil does that. And it's safe. It's 1 drop in coconut oil. And they can use it if they want. They don't have to. A lot of parents tell me they use a little bit, but they hung on to it because it helped them with the teething. So the lip we talked about and the buccal ties. Now, the most difficult part of this whole thing for parents has always been the tongue. Number one, they got to put their fingers in the mouth. Number two, they can't see what they're doing. Number three, it's slipping and sliding. Number four, the baby's crying.
Yeah, I can attest to all of those.
They don't use enough pressure. and they back off. They don't do it long enough. So to fix that, I've developed a new instrument. I don't know, this is not the instrument itself. I'm going to move to the side here. Okay, but if you look, you see that instrument there?
Oh, yeah.
Mhm.
Okay, if you take the groove out of it, because that's a surgical instrument, which I've developed with a company called Armor Dental. But we take the deep groove out of it, and now it becomes a little bit of a heart shape. And it has a very ergonomic handle. The patients are able to get in the mouth and visualize it. And I developed it over the past year, and we give it to the patients to take home. And the result that I've seen has been fewer healing back together, less reopening. And the parents who've brought their second or third child to me have said, this is so much less stressful.
Oh,
So
good.
we went on the market about 3 months ago, and I've given out thousands of them already, but it's almost universally they like it because they can see better. So to start with, the baby's head should be in your lap facing outward. Just like you do an exam, I can't see it in your lap. So I've got the baby's head in my lap, and I push down on the lower jaw and I elevate the tongue. So basically I'm stretching, keeping it open. Some people will do it every 4 hours, 24/7. I don't believe in that. Okay. When ENT says you don't have to stretch at all, it's because most of them only use a pair of scissors. And if it's a full tie from the tip to the base, they only cut the portion that's in front of the salivary ducts, the anterior portion. And that's rarely going to ever reattach because it's pretty thin mucous membrane. But as you go back further towards the base of the tongue, then you create this diamond hole. So what I say to patients is the key to success for the lip and the tongue is simple. You want a diamond. When you stretch a full diamond, if you have a triangle, you're only opening it halfway. If you only open it halfway, it's going to heal. So using the groove, the home unit, the tongue guide, using your fingers, you start the day of surgery about 3 to 4 hours after, and it's 3 stretches. Each one is 1, 2, 3, 1, 2, 3, 1, 2. So you're going 1, 2, 3, 1, 2, 3, 1, 2, 3. I recommend 3 times a day, morning, afternoon, and evening. And the areas turn white. It's not an infection.
Right.
As I've said, I've done probably more than 40,000 laser surgeries. I've never seen one infection. Okay, so that white area is going to last 2 to 3 weeks. Now, the white area is like flypaper. It's very sticky. So if you stop stretching and there's still white in there, and tongue sticks together, it's going to heal right back. So you do it until that white comes off, which is going to be 2 to 3 weeks. And again,
So is that like some people call it the forklift, where you go underneath and then you lift?
Well, yeah, I mean, you could say it that way, but basically what you're doing is you're pushing down on the mandible and you're pulling up on the tongue. And that groove the tongue guide grabs under the tongue. So you push down and pull up. And that's working very well. It's all on my website. I mean, if you want to get a good view, it's there videoed how to do it. And there's a printout on how to do it for you. So you can see it right there. And you can see the instruments. So if you go to Kids Teeth, KIDDSTEETH.com, and under breastfeeding, you'll see the tongue guide. You'll see how to use it, and you'll see comments from parents on, it made my life so much easier.
Well, and actually, so as you were kind of talking about all the tools and stuff, I thought it might be nice to even share the screen and show. This is your website, so you might recognize it. But so this is what he was talking about, the tongue guide, and then all of his post-op aftercare, the educational videos, what we were talking about, how to lift up the tongue, toddler aftercare. I mean, he's definitely you're not keeping any secrets, which is awesome. So
they're all on my website, and anybody can get there.
Yep. Yep, here it all is, which is awesome. So we'll definitely post link into that and be able to kind of show everybody those tips too, which is really, really cool. So I thought I would just share that on the screen here real quick for the ones who watch. So, and the ones who listen, we'll put the link in with the episode too, so you can see what we're talking about.
Well, everything we mentioned is there.
Yeah.
And it's on videos, and there's printouts, and we give the patient a printout, and I show them all. So if you do it the way some people do, like I said, multiple times beyond that, that's where you start to look at the possibility of the baby having oral aversion.
And what is oral aversion?
You go near me, I start to scream. Basically, you see my hands coming, and you know what's coming, and you're going to go crazy. You know how some people hate to go to the dentist? They get sweats, and that's oral aversion. They don't want the person who's coming at them. And you don't want to interfere with the mother-baby bond, because that's very critical and important. So you want to make it as comfortable as possible. So it only takes about 6 to 12 seconds to do it. Now, I like them to go back to their lactation consultant to make sure that they're in the right positioning. They can go to the body worker, because sometimes the babies will come in with a torticollis. They'll come in and they're very tense. And you can see the babies where the mother have had a long delivery and the baby's been stuck. And when they come in, they're like this. They're literally shaking. And I haven't done any, just the exam. So these are the babies you want to be really, careful when you're doing it, to make sure the parents understand they don't have to rip it apart 4, 5, 6 times a day. Now, when you get to the older kids, okay, what am I going to do with the older kids? Well, the older kids, you run the risk of them biting your fingers. It becomes a real struggle. So you can use the tongue guide on, say, 1.5 and 2 and 3 year olds. As the kids get older and can understand, then we start to get into certain exercises. Sticking your tongue forward, left and right. The most important is opening big so you see the surgical site. And how we're going to get them to lift their tongue up. Well, over the years, parents have given me some great ideas. One of the best I ever heard is taking peanut butter, if you're not allergic to it, and the roof of your mouth and licking it. Okay. And then when I tell the kids you have to take medicine for 2 weeks, they look at me like this. I say, at least 1 ice cream cone a day.
Yes.
Popsicles, even a lollipop if they'll do it. So whatever we can get that tongue moving around, so we're stretching it. Or you're going to have to get there physically open it yourself as a parent. But once you're over 2 years old and they start to have teeth in there, you run the risk of losing your fingers. So the device, the tongue guide, the home unit, it really works well for that.
Yeah.
And I see the patients back in a week if they're local. And that's about, well, it used to be about 1/3. Now it's about half my patients, because I'm getting more compliance by the local people, and I'm getting more lactation people and myofunctional therapists around. I still don't get a whole lot of help from the local pediatricians. But I mean, we have to go back to some of our discussion before and understand that the tongue is more than just a muscle.
Right.
And what I've seen just in the last 2 weeks is heartbreaking. If you went to my Facebook page, you may have seen the post last week. I think she was a 7-year-old little girl who was known as a toe walker. They don't walk on their feet. They just walk on their tippy toes. And they had been seeing a chiropractor, and the pediatrician wanted to have her see a surgeon and do surgery, release the Achilles tendon a little bit to get things down. Well, the chiropractor, who's pretty good, sent her to me and said, do you think the tongue could be a factor here? And she was significantly tied. And going back again to some discussion, our body is encased in fascia. And if you dissect the body and you just have the fascia, you wiggle the toes and the tongue moves. So we released her tongue and she walked immediately on her feet. Now, she needs some more body work. But here's a case: this kid would have been put in casts and surgery and general anesthesia. I had a 3-year-old yesterday who was classified as ADD and ADHD and hasn't slept. Okay, and doing the surgery was tough. But the father texted me this morning, surgery was fine. He slept through the night for the first time in 3 years.
Wow.
And he was compliant. He was moving his tongue around. So again, the parents were thrilled.
Yeah.
It was sad today. I saw a 17-month-old baby who was premature. They put a stomach tube into this kid to feed them.
Mm-hmm.
And they went to a feeding specialist and said, I think the baby may be tongue-tied. So we took a look. Not only the lip was wrapped around into the palate.
Wow.
She had 2 big buccal ties and a significant tongue tie. So here's a child who they didn't use the tongue as part of their differential diagnosis. And be honest with you, it's getting very frustrating because we have the ability and the knowledge today to help so many parents and make their lives so much better, and the kids. And, I may have mentioned it again. I think we've always called this a dyad, but it's really a triad today. It's mother, baby, and father. It changed the whole dynamics of the family. The aftercare can be stressful, but reflux for 18 months walking around the house is a lot more stressful than maybe 2 weeks of a baby giving you a hard time.
Yeah.
So
definitely.
Having a kid who can nurse for 2.5 years, if that's what you want. So
as well as the stress of the stretching is hard, but I always tell parents, like, it's a lot easier when they're babies versus when they have teeth because of the biting thing.
Yeah. As a parent whose 90-year-old baby went through it, it is easier, but I don't know. I was like so tender about her in that time. Now that she's like running around like 18-month-old and like, is like falls off things. She scratches herself here. She's exploring. I'm like, you're fine, get up. But when like she was 9 days old, I was like, I'm sorry, baby. It's okay. Like I totally that mom.
When parents, come in the office and we do the surgery and they say to the baby, we're so sorry we have to do this to you. I look them in the eye and I say, look, number one, it's nothing you've done wrong. You don't need to be sorry. Okay. If the baby had a heart problem and you had to have surgery, okay, you would say to the baby, we want to make you better. A baby who has reflux and is in pain all the time.
Yep.
This is not something where you say you're sorry. You say to the baby, honey, this is important. It's going to make you feel better, whether it's a newborn or a 10-year-old. You need to use the positive thing that you as a parent are doing what now is recommended by a specialist to make your life, baby's life, better. I mean, if you don't get that mother-baby bond going, it lasts a lifetime too. So for 2 weeks, maybe, of a crying baby versus a lifetime of feeling rejected or a lifetime of stress or 18 months of stress, the aftercare, and I say it over, is equally important to my surgery if you want to make it successful.
Yeah.
So we don't have to go back in and redo it over and over.
Yeah, that's actually what I kept telling myself. Like, you don't want to have to do this again when she's older. You don't want to have to do it again when she's older. This is going to set her up for success. You're doing the right thing.
You're right.
I give myself affirmations when I was like doing it.
Because you know what? They don't remember it.
No,
I see these kids when they're 2 years old or 3 years old. They may remember when they're 18 months old and they come back for the aftercare and they look at me. Okay. But, I wear a mask, so they don't know who I am.
Oh, yeah, right.
The masks are beneficial. But I think the most important thing here is for parents to understand they're not torturing their baby. They're making that baby's life better, because the effects of, again, the comorbidities, reflux and stuff, this is not something that lasts 24 hours. It lasts their entire life.
Yes.
These are the patients who have airway problems. Okay. And they have problems with neurologic and physiologic and neuromuscular development. So when you come into my practice, you see a 15-minute video, which I put together, which explains to you all of the benefits of what we need to do. And it's not just for the breastfeeding, because some parents will say, you know, I can deal with the pain. Okay, I don't want to put the baby through it. But we need to look at the long-term consequences of not doing it, the long-term consequences of misdiagnosis. And, you know, it's very, very frustrating because it's not once in a while.
No.
You know, I see 10 to 15 kids a day for surgery. And it's the same story over and over about they've seen 3 lactation people, an ENT, 2 physicians, even a pediatric dentist, because we're not taught that. And if you don't know what you're doing and you don't understand it, it's always the same. Oh, they're doing that to pay for their laser, or there's too many frenectomies being done, or it's a fad. But it's not a fad. Today, we have roughly 5 million babies being born and 85% of women nursing. Okay, when my kids were 40 years ago in the 70s, 20% of women were breastfeeding. Okay, so now you have more women breastfeeding. And the studies are all wrong as far as I'm concerned, because when they come and tell you only 5 or 10% of the babies are actually tongue-tied, but 40% of them have reflux. And when you release the tongue, it's not really reflux, it's air-induced reflux.
Right.
So the aftercare, I've said it and I'll say it again, is as equally important as the surgery. And as a parent, you shouldn't be afraid of it. And if your doctor who's doing it has the new instruments, almost universally, parents tell me it's so much less stressful to use this.
Yeah, I've used a tool that's similar by a friend of mine that creates them. And it was very helpful for my autistic clients that I've had, the kids that are autistic that don't like the things in their mouth, and we needed to get in there and do it real quick. Very helpful tool.
Well, there's a lot of different tools for oral hygiene. There's something we call the tongue mate, scan mate, laser mate. If you go to the Armor Dental, it's ARMOR -dental, and look at all of the intraoral soft tissue instruments that we've developed in the last couple of years. And the person who owns the company, the CEO, she actually went to the Special Olympics, and they did over 600 oral exams on all these kids.
Amazing.
It hurt, and you can see what you're doing. And there are other reasons for using it, but we don't have to get into tonight. But aftercare, like I said, is extremely important. You shouldn't be afraid of it. And if you don't do it, all you're going to do is either set yourself up to redoing the surgery and then still having to do the aftercare. So if you do it right the first time and you understand it and the doctor gives you the right directions, you're going to be happier when you come back and see me a week or 2 weeks later. And the baby's going to be happier and dad's going to be happier.
Oh, yeah, definitely. So we go through the aftercare process. You know, like one of the big things with Isabel, because she was so tied and because it was so early on, we also had to teach her how to even like do, you know, latch and suck and kind of go through that piece of things. So, you know, she was barely able to lift her tongue. She would gag when she was trying. So that post-op piece too, trying to even get her to learn how to suck was a whole different world as well.
Well, that's why I like to have the baby sit on my lap and no glove. And I try to get them to make sure the baby's sucking between the 2 knuckles for suck training. And I tell them they can put your breast milk on there or sugar water and spend time doing that. And you put it onto your areola and then transfer the baby. And a lot of times, some of the parents who have not gone to see a lactation consultant, they don't have the money or whatever. A lot of mothers think they need to torpedo the baby rather than bringing the baby to them. So there's a lot of information. I'm a firm believer that if you're going to do the frenectomies on the babies, you need to understand the physiology of breastfeeding, the endocrinology of what goes on to produce the milk and get it out, the bonding of the mother, so that you have an understanding of what the mother needs to do with that baby and what you're doing, not just bring the baby in, do a cut and send them home. You need to educate the mother. And you know what? It doesn't matter if it's the first baby or the 10th baby. When you're a new mother and your hormones are going and you're upset and you're not bonding, it doesn't matter what number baby it is. Okay. Maybe, as you said, when they fall and they get up, you know, when you get your third or fourth kid, you know, they're not going to go to the emergency room. That's a different story. But when it's a newborn, you really want to get that mother-child bond in there. And if you're afraid to do the stretches, you're afraid to do things because you don't want to, quote unquote, hurt the baby, the result is you're not doing anybody any favors because it's got to be done.
Mm-hmm.
Yeah,
True.
Yeah.
And I have this own feeling. I'm doing the surgery. I don't delegate to another staff person to go over the aftercare or to do the exam. I do the exam, show them the video. I do the aftercare.
Mm.
So I know it's exactly what I want. And I have very competent staff. They've been with me for 40 years and they know exactly what we do and support it. And that's another thing. You need the support of your staff when you're doing this. And they need to know what you're doing, what the aftercare is, because they get calls from their friends. A lot of their friends come to me. They don't want to bother me because I give each parent my personal cell phone if they have a problem. But they've got 4 pages of printouts with every question parents ask. And I get very few people calling me.
Yeah, that's amazing. Yeah, just, you know, I think that's so important, is giving the information freely to really help set people up for success, because that's ultimately what you're going for, you know, and being able to have that information on your website and just be that resource for parents, I think is so huge, because that's where so many people get so confused.
Mm-hmm. Also, I heard in a course once, like, that they were told to do the stretch every 2 hours. And it took forever and ever and ever for the wound to heal, because it never had time to try to grow in a healthy way. It was just constantly pulled apart.
As I've said, there are a lot of so-called experts who are out there lecturing and giving information, and it's wrong. You have to be careful. I mean, I'm going to meetings and I'm listening to people lecture. And I've been to a couple of meetings recently where they put up a slide and they talk about it. And then I go over to them afterwards. I don't want to embarrass you, but everything you said on that slide is wrong. Okay. Everything
you're so brave.
Well, you know what? Somebody's got to straighten them out. I mean, you can't give people the wrong information. And when you're lecturing to professionals, I mean, I had a woman get up there. She was, I forgot which part of the team she was, but this was a child of about 18 months whose 4 front teeth were decaying. And she talked all the way around it. And I said, you know what? You talked about the lip tie, but you didn't mention babies who go to sleep with their mother at night with a lip tie and the milk pools around the upper teeth, they start to get facial decay. And it's classical, that notching. I said, that baby has cavities. And you kind of poo-hoo the whole thing there. There's another person out there who's now lecturing, oh, you only have to do the anterior portion of the tongue sometimes because it's too stressful for the parent to stretch. That's the kind of stuff I see coming into my office, which I have to redo. Okay, so some of these experts out there, you know what? I'm better off not commenting at this point.
Yeah, that's fair. But we run into that too, even in our field, you know, like with the myofunctional therapist or in speech or, you know, wherever, you know, sometimes certain people with the loudest voices may not always be conveying the best information. Like just because they're the loudest or just because you're out there the most doesn't always mean, like, we got to look at the research. We got to look at the patients. There's, you know, there's so much to patient care, right? Like I've probably worked with, I don't know, over 700 patients at this point versus somebody else who might have worked with 10, but their social media is like really great. And it's like, well, what are the patients saying? What are the people experiencing? Like when you actually like hit the streets and treat people, what does that actually mean? What does that look like from a practitioner side, from a parent side? Like, you got to do the work to really be able to be an expert in it.
Social media can be your best friend or your worst enemy.
Oh, it's so true. Yeah. Oh yeah. We've all seen that in those Facebook groups of, it can be great to share information, but then
Facebook.
One person gets off track and it's just like a downhill spiral.
And those are the ones who write to Google and give bad reviews to people because they don't understand.
Yeah, I know. It's so hard. Well, thank you so much for talking to us about the aftercare and like, just giving us people more of direction on where to go. Having all those resources on your website is just amazing. And even not just saying how to do it, but showing in those videos, I think is just completely generous and just I can see it taking a weight off of people's shoulders because we start going down these rabbit holes, or parents start going down these rabbit holes, and you're trying to look for all these answers. Like, well, this person over here says this, person over here says this, like what is true? What is, valid? What can I actually do to help?
Or they have the people that they go to the conferences and they're like, I refuse to do a release until they've seen lactation and physical therapists and seen cranial sacral. And then I'll do the release. And then you got to go do more cranial sacral and you got to do more. It's so much. And I think it turns a lot of people off. It's really tough.
Well, you know what? When COVID hit, there was one individual who I talked to, and I said to him, you know what? I'm not going to shut down during COVID. I stopped doing fillings. I stopped doing recalls. But I said, any baby under 6 months of age, we're going to see. And, we have UVC lights. We protected the office. We changed our patterns. We shut down our waiting room. And we still saw a baby once an hour. And then we started seeing them more often. So we never shut down. And his comment to me is, well, you're putting yourself and your family at risk for COVID. I said, you know what? I put my family at risk every day for AIDS, for hepatitis. But you know what? We wear protective gear. We wear masks. We wear gloves. We're very well protected. And we sterilize and keep everything clean. And we keep patients away. We have 4 conference rooms that are totally separated. And are private. And then what I did is I took my waiting room and I cut it into 3 different areas for aftercare. So I didn't have the parents, when they came back, have to go into that room. They would still be separated. So we could see sometimes 5 babies at the same time for different aspects, but they were away from each other. And we were gloved, gowned, and bibbed and everything.
Oh, yeah.
So his answer to me was not putting people at risk, him and his family. I said, well, if you feel that way, then you're not doing the right protection if COVID didn't occur for your other patients. Okay. So we didn't agree to disagree. We just disagreed.
Yeah.
Same person, doesn't see Medicaid. He doesn't have patients from out of state he'll see, because he has other things he wants to do. But he's an expert. And some of the information was good in the beginning, but it's not good now. So I know of many of the people out there speaking have been in my office years ago, and they're good. But I also know there's some of them out there who just got this problem that they're the most important thing ever made. And they want to go into the OR and tell the doctors how to do the surgery and all that kind of stuff. And I just find that kind of ego stuff is just not good.
No, there's no room when there's people in need.
So we need to take the patients and work within their economics, their finances, and not turn them away because they can't afford all of the other members and auxiliaries, because if that tongue is tied, all the other stuff isn't going to work.
That's a great point.
You have to release the tongue and work with the other people. But if there's a problem and they can't get to it, I have a flow sheet, which I talk about. The delivery room doctor or nurse should take a look, just like they check everything else. The lactation person in the hospital should take a look. The midwives to me, they're amazing. I think all of them know what to look for. And a tremendous number of referrals from midwives. Okay, they may go to a lactation person, but depending on the degree of attachment, is going to depend upon your pre-care. And the aftercare may be a little different, because if it's a very thick frenum, the chances of the baby being more uncomfortable are greater than if it's just real mucous membrane.
Right.
So anyway, we don't want to get into the surgical procedures and all that stuff right now. It's a 7-hour lecture and we're breaking it up in 2 hours.
We won't make people do that. Well, thank you again so much for A, coming back, and then B, also just kind of sharing more about that wound management and aftercare. It's been such a privilege to steal your time, multiple hours
I enjoy it. I mean, I really would like to be able to educate more people.
Yeah.
I wish you were both physicians and you could spread the word to the medical community. That would be my goal. Would be give this lecture to the Academy of Pediatrics and the ENT people.
It'd be amazing.
That's like, trying to get into the, I don't know where, someplace behind locked doors, maybe Fort Knox.
Okay. There you go. Awesome. Well, of course, we're going to post all the information for you guys. Kids Teeth, DDSteeth.com. You could find myself and Kimmy online at the Munch Bunch podcast, or individually at Northwest Myofunctional Therapy and WFT, or at Mouth Muscle Memory. Dr. Kotlow said he can talk for 24 hours straight. So if you guys want to bring him back for a third episode, you just let us know.
You let me know. I'm always available.
The Dr. Kotlow podcast.
Or
all right.
The talkathon, the 24-hour talkathon.
Yes. We'll bring snacks.
My pleasure, guys.
All right. Thanks, Dr. Kotlow.
Thank you. Bye-bye.